This is a 52-year-old male who is referred for evaluation of a 2-year history of progressive dysphagia to solids and liquids and a 40-pound weight loss over that time. An initial barium study revealed a dilated esophagus without barium entering the stomach. Esophageal manometry revealed aperistalsis and incomplete relaxation of the lower esophageal sphincter after wet swallow, which is pathognomonic for achalasia. Endoscopy was performed to rule out pseudoachalasia secondary to malignancy at the cardia. After the risks and benefits of pneumatic dilation versus other treatment modalities such as surgical myotomy or injection of the botulinum toxin into the LES was explained to the patient consented to pneumatic dilation. At endoscopy, copious amounts of food and liquid were seen in the obviously dilated esophagus. In order to safely remove the food, an overtube was placed and the food was removed by a Roth net. An alternative to this would be the use of an Ewald tube. After removing the food and liquid from the esophagus, the characteristic pop is felt as the endoscope is passed through the tight lower esophageal sphincter into the stomach. A complete examination was performed in the standard fashion with attention to the cardia and the gastroesophageal junction on retroflexion to rule out malignancy in this region. A stiff guide wire, in this case a savory guide wire, is placed in the antrum under fluoroscopic guidance. Then the endoscope is removed as the guide wire is kept in place. The rationale for dilation is to produce a controlled tear of the lower esophageal sphincter, which will result in relief of distal esophageal obstruction. This is the most effective non-surgical treatment of achalasia. Pneumatic dilation is associated with a 60 to 90% initial response rate, with a 60% response rate at 5 years. There's also a 3 to 5% risk of the perforation with the procedure. The Rigiflex balloon, made by Boston Scientific, comes in 3 diameters, from 30 millimeters to 35 millimeters to 40 millimeters. A 30 millimeter balloon is used initially, with larger balloons used if no improvement in symptoms is noted. Larger balloons, however, are associated with an increased risk of perforation. Most experts, with some variation, generally follow the following algorithm published in 1998. In this case, a Rigiflex balloon with a 30 millimeter diameter was advanced over the guide wire with the middle of the balloon traversing the GE junction, as indicated by the 2 radiopaque markers in the middle of the balloon. A 50-50 mixture of radiopaque dye is injected into the balloon, and the balloon catheter is gently moved back and forth to spread the dye throughout the balloon. The middle of the balloon is generally held about 1 centimeter above the GE junction as traction of the balloon upon inflation moves the balloon distally into the stomach. Once the balloon is in place, the catheter is held firmly against the bite block to prevent migration of the balloon. Here the waist of the balloon is noted, which is at the tight lower esophageal sphincter. The balloon is inflated slowly until the waist is obliterated, which is usually 7 to 10 psi. There is no consensus on the duration of inflation. Some centers repeat the dilation and document that the subsequent pressure is lower. After dilation, the balloon is removed and examined for blood, indicating a tear of the LES and an adequate dilation. A subsequent gastrografin study was performed after the procedure to rule out perforation. Here, dye entered the stomach without evidence of an esophageal leak. The patient was observed for 4 hours after the procedure without any significant chest pain, was tolerating liquids, and was discharged with follow-up with a barium swallow in 1 month's time to assess esophageal emptying.